Hello, my name is Sarah Chimera,
And I'm Mary Geen.
and we are graduate occupational therapy students at the University of Scranton. So, welcome to our historical analysis discussing the progression of occupational therapy for individuals with traumatic brain injury from the 1900s to the present. Throughout this presentation, we will discuss relevant literature and trends related to the treatment of persons living with traumatic brain injury.
In our first decade from 1910 to 1919, we identified the theme of early case studies of brain injuries. So the early research in this decade consisted primarily of case studies that discussed the symptoms that occurred following extensive trauma to the head. Symptoms that are listed often in these case studies include hemiplegia, paralysis, headache, and visual disturbances. The majority of traumatic brain injuries at this time were caused by war or battle injuries, which contrasts from the majority of TBIs that are caused by falls today. There's a lack of knowledge on treatment because at this point in time, scientific and technological advances did not allow doctors to identify the location of many injuries. So therefore, it was difficult for doctors to discuss how the injury to specific areas in the brain contributed to frequently observed symptoms. So there's very little discussion within the literature that discusses the efficacy of rehabilitating patients with TBIs. And negative terminology was often used in order to discuss mental health or cognitive challenges. Like, for instance, the term FITS was used um, to describe seizures, and individuals with cognitive deficits were called simple minded. So moving forward to the 1920s and to the 1929s, this decade had the focus of head injuries and the evaluation of changes in the brain and the subsequent treatment. The first step in understanding the extent of a head injury is gathering the full detail of the occurrence of the accident. And this can be done by asking people around or asking the patient what happened. And then you also take into consideration the external and internal presentation of the head injury. So when evaluating, the therapist should observe and note any deviation from normal behavior, mentality, and the physical state. In this decade, the long-term effects of a TBI had not yet been studied in depth. And because of this, any remaining symptoms were not taken seriously. And it was assumed that patients only claimed to have any continued effects just to receive financial compensations, such as workers' comp. So early research on the treatment of head injuries emphasized bed rest, specifically the Trendelenburg position, and for no reason should the patient be let out of bed until he has been headache-free for at least 7 days. And the research in this decade also claimed that the patient and family members should be left in the dark on the extent of the injuries because the first step is to rest, and then subsequently any complications would be treated. And now we'll move forward to the next decade.
So, literature in the 1930s discusses the function of the brain and the classification of injury following a traumatic brain injury. So, often we look at the brain function subsequent to the traumatic brain injury. So, this looks at like recovery patterns, which were examined related to brain function recovery, which helped therapists at the time to predict the prognosis and safely plan for discharge. Russell wrote that the lower mechanisms of the brain recover first. These include the involuntary movements of the limbs, speech, and purposeful movements. Second is the higher cerebral functions. And many patients show residual deficits in these higher cerebral functions, including memory, judgment, and personality. So these deficits are often slower to recover and in some extreme cases permanent. In addition, Russell in 1932 began to group cases of head injury by the period of the loss of consciousness to predict the duration of recovery. 2 years later, Schaller in 1939 classified head injuries as organic and functional, depending on the presence or absence of structural changes in nervous tissue. Organic injuries are more evident and place pressure in the brain. Functional injuries consist of mental complexes following acute symptoms. Arising from the head injuries can be brain abscesses consequent to latent head trauma. So the secondary symptoms vary with the cause, site, and size of the abscess. The evolution of the abscess can be classified into three states, and from here, the therapist may be able to predict the accompanying symptoms. Regardless of the classification of the injury, throughout this decade, they're grouped by the severity of the injury to predict the brain function following a TBI. Within the 1940s, this era further discusses the principle of treating a patient with a traumatic brain injury, as well as incorporates the scope of OT practice in this area. The literature compiles multiple intervention strategies that showed significant improvements in recovery of the patient, although some strategies are no longer widely recommended, such as the use of restraints or sedation. Friedland and Margolin in 1947 state that upper extremity function was very difficult to recover because it requires much more coordination, and engaging and increasing coordination is important and can be done through participation in sports. Denka in 1946 added that patients with hemiplegia can participate in meaningful activities that utilize their unaffected side, such as art. In terms of proper treatment and occupational services, McCormick and Long state that no amount of time, trouble, or effort should be spared in rehabilitating patients. The patient responds best when treated as a normal person. Today, OTs continue to work holistically with the client, not with the disability, and this has been true as far as back as the 1940s. In treating holistically, the patient's family can also be incorporated into therapy, which is done to this day. Family members can assist the therapist in re-education. They should also be educated on what to expect for recovery, which is very different from what Mary shared within the 1920s. However, the same treatment was sometimes not provided to patients with symptoms such as impulsivity, apathy, poor judgment, and poor affect. Often doctors believed that these patients were pretending to have symptoms in order to receive funds from the government. So that is a trend that did continue into the 1940s as well. Now we'll continue into the next decade.
So from the 1950s to 1959, the theme continued that individuals with post-traumatic syndrome following a TBI were not taken very seriously. In 1951, Lawrence described patients with PTS as annoying and self-limiting. So at this point, longitudinal research began to examine the long-term influence of TBI on veterans of World War II. So early research examined seizures and physical effects. However, one researcher urged medical professionals to begin examining the patients as a whole in order to assess their quality of life following an injury. Many theories behind OT in the 1950s were based upon the idea that engagement in occupation would reignite the damaged parts of the brain. And research discussed the use of teaching individuals to utilize the non-dominant hand following hemiplegia of the dominant side. In addition, a primary focus among veterans that served in World War II was to encourage trade or work skills following an injury. This can include woodworking and carpentry. And in the 1960s, 1969, professionals began to introduce the concept of prevention for TBIs, including reducing alcohol use and using helmets for protection. At this point, the literature begins to acknowledge depressive symptoms, confusion, and altered mental state as symptoms of TBI and worth examination. However, the literature continues to demonstrate that individuals with symptoms of accident neurosis, it's now known as post-traumatic stress disorder, following a head injury were pretending to in order to receive financial compensation and retire similarly to other decades. At this point, professionals began to advocate for therapy to begin as soon as the individual can tolerate it in order to improve outcomes. And this was a huge advancement in treating TBIs. So now we can talk about the next couple decades.
All right, so within the 1970s, enhancing cognition was a primary concern. However, knowledge about how to remediate or compensate for decreased cognition was still unclear. At this point, doctors continued to make estimates regarding the prognosis of individuals with TBI. Medical professionals began to use the Glasgow Coma Scale to determine the prognosis and outcomes of patients. However, Lezak in 1976 continued to discuss how recovery, particularly cognitive recovery, had a high degree of variability. Severity of injury was the most commonly used way to estimate these levels of recovery. In addition, aphasia was often observed among individuals with TBI. The most common type was anomic aphasia, and this tends to be more mild in nature and results in word finding deficits. However, Hellman et al. Found that recovery for these deficits and increase in communication was highly variable, and few strategies demonstrated clear evidence of efficacy. In the 1970s, evidence began to demonstrate that reaction time was affected among individuals with TBI. Brooks found in a study examining memory that patients with TBI were more likely to fail to recognize recurring shapes, but were less likely to falsely recognize shapes. These results began to formulate the idea that reaction time was delayed and that individuals with TBI may be overly cautious in making choices. Now we will move on to the digital age.
So in the 1980s, there was a strong push to examine the efficacy of specific treatment protocols and occupational therapy among individuals with a TBI. This aligns with the push to conform with the medical model and encouragement of evidence-based practice at this time. And due to an increased need to prove the efficacy of treatment among this population, the literature began to examine the best way to demonstrate the effect of occupational therapy through research studies. The research discussed that many studies often are overly ambitious and do not have accurate controls or reports due to the large nature of their sample size. Therefore, the researcher reports that the need for increased, well-formulated experimental studies to demonstrate the efficacy of OT among individuals with TBI. And this transitions us into the 1990s, where there were several experimental studies that we found in our research that focused on determining of the efficacy of increasing the use of occupations in practice. One study found that subjects in the functional meal preparation group and who did kitchen activities showed significantly greater improvement in their dominant hand dexterity for picking up small objects than the subjects in the group that did a tabletop just puzzle activity. And another study compared the benefits of early intervention and late intervention. And as we had talked about in prior decades, that research determined therapy as soon as possible leads to greater outcomes. So this was evaluated in this research study. And in a third study, it evaluated behavioral methods to redevelop self-care skills. And 3 out of the 4 subjects achieved rapid independence and washing and dressing themselves. So all 3 studies proved the evidence of the benefits for the increase in the use of occupations in practice and gave us some evidence base and provided efficacy on the benefits. So now we can move on to the 2000s.
Within the 2000s, the early 2000s, enhancing upper extremity and cognitive functions was extremely important. So the literature examined levels of self-awareness among individuals with mild versus moderate to severe TBI. By 1 year post-injury, the level of self-awareness for the participants with mild TBI was not significantly different from those with moderate or severe TBI. And however, the pattern of development of self-awareness was different between the 2 groups. So the participants with mild TBI initially overestimated their deficits, but demonstrated good self-awareness throughout. The participants with moderate to severe TBI significantly underestimated their deficits, but demonstrated a gradual increase in self-awareness, which is important to note for occupational therapists so that they can gear their treatment sessions appropriately. Next, the literature examined therapist perspectives related to both handling aggression and clinical decision-making for upper extremity deficits. So the findings by Blue in 2007 suggest that occupational therapists need to increase their awareness of the problems associated with aggression. So the study identified that in the presence of the elements of close physical contact or fear, and where adults with a brain injury were unsure about what was going to happen next, aggression was more likely to take place. It appears necessary to explore further why this is and to establish strategies to reduce the perceived threat to adults with a brain injury and the potential risks to therapists. In addition, when examining the factors that influence the clinical decisions of experienced occupational therapists who worked with either children or adults with upper limb performance dysfunction with brain injury to determine if the clinical decision-making process was common for all clients with brain injury. So Cooper's et al. Found the response was dependent on the client conditions and needs and the OT's knowledge and confidence in their skill, and also the culture of the environment. So there was a great deal of consistency among the factors associated with the clinical decision-making process. Therefore, it does seem that it may be plausible for there to be some kind of protocol for the decision-making process among patients with who require upper limb recovery that may be efficacious. In the 2010s, they were marked by the examination of interventions used by occupational therapists for traumatic brain injury, examining how frequently certain types of intervention were used, such as visual impairment interventions. So results by Blanchard et al. Demonstrated that compensatory strategies are the most common intervention used by occupational therapists to address visual impairment secondary to TBI. This was followed by neuroplasticity theory-based interventions, and evidence does support the effectiveness of compensatory strategies following assessment and consultation with an eye doctor. In addition, according to Holmqvist et al., Swedish occupational therapy practice for clients with cognitive impairments following acquired brain injury focuses highly on occupational performance. So therapies targeting executive functioning seem particularly important in practice, and a collaborative approach involving clients, relatives, and other staff is a prominent feature in this practice. In addition, the outcomes of using cognitive perceptual motor retraining were examined by Christie and Huffine. These findings demonstrated positive outcomes such as safe discharge and increased independence. And lastly, while warfare injuries are no longer the main cause of TBI, as we discussed earlier, occupational therapists continue to examine the specific occupational needs of service members following combat-induced TBI. Through a descriptive study, service members who had sustained a TBI described what occupations were influenced by their injury. Two main themes were identified: occupational changes and plans for the future. Occupational changes contained 6 sub-themes, which included rest and sleep, activities of daily living and instrumental activities of daily living, work, social participation, play and leisure, and education. And plans for the future contained 3 sub-themes: supports, barriers, and fears. So all of these are important to take into consideration when treating military service members for TBI, because these are often the occupational areas where they need the most assistance.
So in conclusion, you can see that the research and the literature about TBIs has drastically evolved since 1910. So thank you for listening to our historical analysis of TBIs and the role of OT in this practice area. Please contact us at our emails on this slide with any questions that you may have, and we'll be happy to answer you. Thank you, guys.
Thank you.